So this patient has had a evolving inflamed epidermal cyst over the course of the last how long now?
Since it's been inflamed?
Yeah.
About a month.
A month, eh? The problem she had is nobody wanted to open it up, and the plastic surgeon didn't want to see this either directly. And the problem with it is we can't remove this because it's infected, so we're going to have to just see if we can get it to drain. So we're going to put some anesthetic in. Problem with this is lidocaine works on an acid-base mechanism, so the anesthetic is a little bit acidic, and the basic tissues usually convert that to more of a neutral substance, which is then soluble into the actual tissues. When there's an infection like this, it's also acidic, so the anesthetic doesn't work as well. So we're going to inject some deep and see if it'll take a little bit. You can feel a poke here, poke. Feel a little pressure. Now I try to get behind this cyst, but if I'm into it, you'll see that pressure starts to exert on the cyst, and those will start to pressure forth. It looks like I'm underneath it still. Oh, you can see she's having pressure, back pressure. And now I'm going to put a little bit on the superficial tissues. Again, this is just to sort of hopefully anesthetize some of this. See where it blanches a bit. You okay? So we aren't looking to do a large incision here, so we just want to get it to drain. And I warn residents to not be right over top of these cysts because they can get a lot of back pressure. And I've seen many residents who will actually shoot themselves in the face. Not too bad. So for this, I use a number 11 blade. It's the only time where I'll use a number 11 blade. Now the incision to choice, we follow along Langer's lines. I should mention those. Those are connective tissue lines that dictate how well you'll heal. They run parallel to the muscles, so in the neck, they're actually horizontal. So you wouldn't do a vertical incision here, you do a horizontal incision. The initial incision, now you're going to get lots of purulent discharge. So I always have lots of the 4x4s ready. Same thing here. Can't see because I'm out of the film, but you'd want to make sure you're not right above cyst, or the particulate matter will shoot right up into your face. Now it'd be nice if we could take the capsule out. The problem with these is when it's infected, the capsule becomes thin and friable, and it's impossible to take it out. So all we can hope to do is to get it to drain. Now sometimes I've found when we're repacking this, a couple days from now, it's possible to get at the capsule and get that to come out, but right now that's not possible. So we're getting towards the end of it, and you can see how much less inflamed the tissue is already. And normally you can see a nice capsule. Here you can't because again it's so thin. So now it's not draining much. Now when you're first filling this in, she's got some anesthetic in, so you can be a little bit less gentle with it, but certainly when you're doing the changes in subsequent days, you have to be a bit gentler with this. And on the first day, you want to put it in pretty firm, and you want to fill it up completely because it wants to absorb some of the residual bleeding and the residual purulent material. On subsequent days, you actually want to be putting in less and less so it has a chance to close up naturally. And you'll see that this will absorb a fair amount of this gauze. Because obviously that pocket is fairly large. Now this, they will be, once I've done the initial incision, they'll be okay with changing it. So you just go to the clinic and they'll change that for you. You okay? I'm almost done. And this can seem to go on forever sometimes. I'm starting to get more resistance. You okay? I know the position's a little bit uncomfortable because you're on face down. And then I'll just clip this, and then we'll put a dressing on it. So you can stop if you like.